Dr. Mehta, for those excellent words. We very quickly now move to our guest of honor. We have very eminent Dr. Peter Lachman with us. Thank you so much, Peter. Peter has been joining us from Dublin. And it's a weekend, and Peter has very graciously, agreed to be a part of this meeting at a time which is not very convenient for him, but still. And thank you so much, Peter. We thank you for your patience. Just to introduce Peter. Peter, besides being a close friend, is Chief Executive Officer of ISQua. He's a co-founder and chairperson of PIPSQC, the International Paediatric Patient Safety and Quality Committee. He's a lead international faculty at RCPI in Dublin, where he co-directs the leadership and quality programs. He's developed the QI program at the Great Ormond Street Hospital, where he was the deputy medical director and lead for patient safety. And that is when in 2015, I and Peter met. So this was the time. It's been a long journey, like more than 5 years since knowing Peter. We've carried it. And I would like to mention here that it was Peter's visit to Kalavati Saran Children's Hospital in 2015, and it was a rainy day. I still remember Peter and his visit to my chamber. And that was the time that the seeds of quality improvement were sown in the NQOCN network. Peter is also a formal national clinical lead for situational awareness for everyone's safe, the Royal College of Paediatrics and Child Health RCPCH program to improve situational awareness in clinical settings. So we will now, I'm going to be stopping sharing the screen, and I would be requesting Peter to start his presentation. Peter, the screen is all yours.
Okay, thanks very much, Vikram. Can you see my screen?
Yeah, that's fine.
Yes, it's visible.
Okay, let's get the slideshow going. So firstly, I want to thank you for this invitation to me. It's a great honor to be with you. I remember my visit to New Delhi in 2015. I've actually been back to Mumbai since then, but just a very quick visit. So to all my friends in India, I want to say hello and thank you for having me here on this very important day. I'm going to spend the next 30 minutes or so talking about a very important thing, is that when you start a point of care improvement program, how can you sustain it at scale and spread? So I'm going to take you through a bit of theory, a bit of fun, and let's see how we go over the next few minutes. Firstly, just let me tell you about ISQua, because Vikram is an ISQua expert, and the community of practice has joined as an ISQua member. And this is very important because you join a community of learners. We are growing in the region. I have institutional members in India now, the Kaho, for example, quite a few to mention, is that we are now growing in the region because people understand that one has to learn globally, and particularly this COVID pandemic has taught us that the solutions are not based in one country or one community, but are universal solutions. So therefore, we need to out there to the people. So that's what our role is. And how do we do it is by providing knowledge. And we have many programs to do this. We have already a big network. And once you join us, we're part of a network. And we aim to give people a voice to speak out and share what they know. So these are the 6 domains of quality that you heard from Dr. Reiner, and I have been thinking hard about these domains, and I think that they need to be adapted slightly. So just what's going to happen, person-centered care is not a single domain. It's in every domain. You can't have safe care unless you're really person-centered. Effective care is about being person-centered, as is efficient care, and so on, and particularly equity. And the new domain that goes in is that of eco-friendly care. And this is even more important now as we sit in the pandemic, and we suddenly realize, I've seen pictures of in Delhi of how they, without the traffic and out the airlines, how you can suddenly see. I've seen that around the world. You have seen what has happened with the climate change. impacts of the pandemic. And of course, the pandemic was part of spread by travel. So we need to be eco-friendly, and we have to think about our hospitals. And then we have to think the core of why are we in healthcare. And that is really, it's about compassion, respect, partnership, and co-production of care with the mothers that you'll be working with, the families, or the people we call patients, and having a holistic approach, which you in India understand more than anyone else, how important it is to look at the body as well as the soul. And then we have to be transparent. And this is the foundation of good governance, is being open with what we do and being prepared to share how things go well and when things don't go well at all. So this is the quality system that now I am going to talk about. And we need to make sure that this quality system is in place at all times. To do that, I'm going to revert back to quality improvement methodology. And the first one comes from Donna Beedham, who says, if you really want to improve, you have to understand your system, how it works. You have to understand the processes, how you get the work done, and then you'll know what will happen with the outcomes. So those are basically the foundation of all quality improvement, and what follows is really about how do we make that system work better in order to get better outcomes. And what you heard from our previous speakers was all about this, understanding the system to get the better outcomes and really looking at the variation. So the next one is to look at the theory of Durand, and this is the quality management system. So in order to do this, every clinical team, every team at the bedside, every management team, every hospital, and every nurse has to have quality planning. It just doesn't happen. One has to plan for quality. It's not something that's going to come out of the sky. And this is what you heard on the 4 steps previously. That's about firstly planning. And then you've got to set in quality controls or measurements. That means these have to be constantly controlled and you're constantly looking at how you're performing. And then of course you have quality improvement, which leads back to quality planning, to quality controls, to quality improvement. So this is a never-ending cycle, because when you have your controls, which are your measurements, you are going to see whether or not you keep to that, and you're going to look for deviation from the control. So those 2 slides tell you about what you have to do. And now you go to the third one, which is understanding what improvements. This is from Deming, and to me, he called this profound knowledge. And as you know, that the word profound kind of means that you never really understand the deepness of what it says. And I've been studying Deming for the last 15, 20 years, and I learn something new every day. And the first thing Deming said is you have to understand how the system works. So that leads back to Donna Beedham. And then he also talks about the processes. And what Deming said is that if you study variation, and so these 2 are linked in, and then Deming adds the psychology part. He says, well, the processes are formed by people who make up the system. So you have to understand their belief systems. And a good example here is that we've always had a problem with hand hygiene in hospitals. In most hospitals, you'll find the nurses have fairly good hand hygiene, up to 80–90% of the time, yet the doctors hover around about 40–50% of the time. Even though you have hand hygiene notices all over the place, it's the doctors. But as soon as we had COVID, that changed. And now hand hygiene is around probably 100% of the time in most places, in most settings. People are obsessed with hand hygiene because we have a threat. And so it's the belief system that's very important when you're thinking about keeping this going. And I've been asked to talk about sustainability, and I think it's about changing the belief system that is essential. And then we have to look at the way we make changes to improve, and that is the quality improvement process. And you've heard of a number of methodologies, and it depends really on where you're working and what you do. So you've heard about the PDSA cycle, and that comes from Schwartz, and that has been involved when they put it together in the model for improvements, one version. You can use it in Six Sigma, in DMAC, you can use it in Lean, in the 5S. So it doesn't really matter, you just have to have a method. The theory is based on Deming, and so they all come from the same source, but they're appropriate for different areas. So what you really want to teach people how to do, and when I was looking at the manual, it says, how do you study your system to see your opportunities for change? You look at your variation in your processes, you get your team together and look at their belief systems, and then you start with an improvement project. And so this comes from the source. But healthcare is not simple. It was easy in the old days, possibly when I grew up, you went to your doctor and there wasn't a layer of complexity in those days, and that's not that long ago. Many cancers weren't treatable, many diseases weren't treatable. So there was not this complexity we have, but now we have clinical complexity and complex adaptive systems. When I was a young pediatrician training in Paediatrics in South Africa, we had a simple rule because it was before surfactant. Any baby under 1,000 grams, we weren't going to ventilate because the outcome was very, very poor. Then surfactant was discovered, and of course, then you could keep babies alive much easier. So the clinical complexity grew because what we started seeing was now the complications of keeping small babies alive, like ventilator-associated pneumonia, retinopathies, etc. So our complexity changed because we solved one of the problems. And also the way we design healthcare is complex in adaptive systems. Then we have the culture of the organization, both individual and the system culture, which I'll come back to in a second. And finally, we have the individual processes, which we call the human factors. So these are the complexity of the system. So when you are looking at long-term improvements, what one has to do is look at how you can do that. So I find this model particularly good. It is called the SEEPS model, the Social Engineering Patient Safety Model. It's an initiative. It's from Pascal Carrion in Wisconsin. And I find this a very useful model, even not in human factors and patient safety, to understand how your system's working. So your work system at the point of care have people, those are the providers of care, the nurses, the doctors, or the support staff, and has patients as the neonates and the mothers. You have an internal environment which you need to address if it's safe or not. You have tools and technology, and intensive care will be far more complex than a high dependency care, but you have tools and technology, or you lack tools and technology, and you have tasks to be done that people must be able to do those tasks. And finally, you have the way you organize this. And this can be simply done at the point of care to understand how your work system is done. And you have external environmental pressures. For example, now COVID is an external environmental pressure. And then you have your processes of care. As you can see, this is linked to Donna Bedian. And the process of care is how we do the work, how we work with the patients, how do we involve the mothers, do we involve them in the care of their babies in the hospital, when they're in intensive care? Do we involve them in the feeding? Do we involve them in anything at all or not? And then you have outcomes which are either desirable or undesirable. And I'm sure you want to have only desirable outcomes, and that could be desirable or undesirable for the patient, the professional, or the organization. And then you have feedback loops. I've gone through this very quickly, but you'll have these slides, and I can give you the papers. These are free papers to get, in which you can really understand how to analyze your system at all times. And you can train clinical teams to do this, and it is really not that complex once you've taught them the simplicity of understanding a complex problem. Is how does your system work so I can improve it? And that is a human factors approach. And then Dr. Reiner mentioned the habits of the improver. So I put this slide in quickly to make sure that you see a construct. This is the one from the Health Foundation, which I can make available to you. And what you really want to do is have this understanding of how work is going to happen. And that means having systems thinking, and that's what I was teaching in the last slide. Have learning, and that's what you heard earlier, that we have to learn continually, and if we don't learn, we're not in it. Learning means you have to solve problems, you have to look at, be reflective, you have to be able to influence others and be conflict. This is very important. You have to be very confident with conflict that people are going to say, no, we don't want to do things. So influencing is very important. Resilience is an interesting one because we don't really look at it, but tolerating uncertainty is really important, and knowing how to take risk and being optimistic. And finally, you have to have communication and creativity, knowing how to get ideas. This is for me is an essential part of ensuring sustainability, because if people do have that habits of being improvers, then they're going to improve. So here's a paper that I wrote. I suddenly realized that I have written a paper on neonatal intensive care in the case for quality improvements, and I can make this available to you. It's really showing that quality improvement is part of our work, and even more importantly in the neonatal units. So there is also the hub and spoke that you heard about. So I put this in just to show that this is a very important paper too. Now let's go into where it starts. In order to get sustainability, one has to have a culture of safety, a culture of quality. And this is the first part that you have to deal with when you're looking at healthcare improvements. And what is the culture? What do people believe? What is their belief systems? And one has to really address this. And this is the part of dealing with conflict that you have to have, because you're going to have a range of belief systems and a range of cultures in your organizations. And as you spread from one part of India to another part on a national collaborative, the north is going to be very different from the south as the east to the west. And when you go into the region, you've got these cultural issues that one has to take into account. And what you need to do in this assistance is understand and respect culture, but be prepared to challenge behaviors that go against what you want to do. So now I'm going to give you just about 10 steps that I think are important as you go forward. The first one is always to celebrate success and celebrate good practice, learning from excellence. We often forget that in healthcare. So I think celebration is really an important part of what you have to do, and you need to celebrate at all times. And so, in the patient safety field, we're always looking for what went wrong. In the quality improvement field, we should always be looking for what goes right and then try to replicate. So this is where celebration comes in. And that means that as you're starting now with your new collaborative, it's a new beginning. And as a small plant grows, you have to nurture that plant. And how you nurture is by building the resilience and by really celebrating as we go forward. So the new beginning is very important. The second step is reflection. Reflection on how you work as an individual, how you work as a team, how you interact with the patients, the people who you provide care to, the parents, how you view life in general. And I think this in India would be much easier than many other places. But reflection is an essential part of what we do. And I think that you need to keep this in mind at all times. The step 3 is, as you heard Dr. Mehta said, you have to apply what you learn immediately and apply it and apply it again and learn from mistakes. The example that Don Berwick used to say is that when you learned to ride a bicycle, you had to fall a number of times before you learned how to ride. And that's exactly very important in quality improvement. You have to apply your learning and apply it quickly after learning. Now we get to looking at the processes. We tend to overcomplicate our processes. So when you study your work system, Your aim is to make it simple and to make it easy to do the right thing and make the right thing easy to do. And that's very easy for me to say because we have complex systems and we overcomplicate them. So the first step here, step number 4, is study your system and simplify. And that is based in the lean methodology, which is aiming at doing just that, is simplifying systems and make it easier to run. And in order to do that, the next step is vital, the step number 5, which is standardize. So we have to standardize what we do. And I have another paper I forgot to put in, is about standardizing how we prevent line infections in intensive care. It's through a care bundle. So standardization is important, and the quality improvement approach here is standardize where possible and vary only where necessary. And that means, for example, you heard earlier about antibiotics stewardship, is that we need to standardize the way we provide antibiotics and only give outside the process if the patient demands it because of their clinical condition, not because we do it that way. The next one is to lead. Leadership is going to be, and this is not only the nominal leaders, it's that everyone in a healthcare team needs to be a leader and to lead at different points of time. And so leadership is an essential part of what we do in healthcare. Now this collaborative is about this very step. It's about mobilization. I'll be talking a bit later again. We need to mobilize people, and this is to make quality improvement a social movement and mobilize people in small groups and in large groups as well. And this is where the community of practice is going to work, is how to mobilize people into action. And then, of course, we have to build coalitions. Again, the community of practice is about this, building coalitions so that you can build a system that you can make things better. And then step number 9 is collaborate. In this case, the wildebeest has got very good eyesight, but a very small smell, and a very poor smelling, and the zebra, poor eyesight and very good smell. So they are always together so they can combat the threats. And so you have to collaborate, and by collaborating means that every member of the team has a different strength, and the SAFE program, Situation Awareness for Everyone, was concentrating on collaboration between different professionals and different parts of the organization. And now we get to the big part, is sustain. How do we sustain what we are going to do? Now, often what happens in quality improvement is we don't think about this at the beginning. We think about it at the end. We do our project and then we start something else. The collaborative ends, the program ends, and what happens? There's reverts to the mean because we haven't thought about sustainability on the first day. So my advice to you here is that when you start in your quality improvement initiatives, you start talking about how we're going to sustain when we are not doing this initiative, when the money is finished and we're on another initiative. So for example, if you're having a program to decrease line infections in children in hospital or in intensive care, what happens when that initiative ends because you've achieved your outcome and now you're on to decreasing something else like tissue injury, for example. So sustainability is very important. And here are just 2 methods that you could use. This is the one I like from the National Institute, the NHS Institute, which no longer exists, but I've had these, the model if everyone wants it. And it really talks about the elements that you require. And for sustainability, you have to start on having benefits beyond helping patients, that it must be also good for the staff. That's very important, and the organization. There must be credibility of benefits. The benefits must be adaptable to different contexts, and you must have a system of monitoring, going back to Duran, a control system, so you know how you're doing. So that's the first thing about your process. The next one is about your staff. You need to know whether you have senior leaders on board clinical leaders on board. They could be the same people, but they might be different. You have to understand the behaviors, the belief systems of people, and you have to look at the training is required. And finally, you have your organization. That has to have whatever you want to do has to fit in with the culture of the organization and the infrastructure. Now, in the model, they have a scoring system, but you don't need the scoring system. You can just mark at the beginning, when you start your project, do I have these in place and do I pay attention to them at different parts of the project? Now, this is that one sustaining model. I want you to show one other quickly. And this is what happens in, and this comes from a paper on sustainability framework. This is what happens to programs. You have two things that could happen. You have program drift. So you have your intervention, but over time, it drifts to something else. Or you have voltage drops. So it has a big impact at the beginning, and over time, the impact gets less and less and less for many different reasons, which I don't have time to go through. So this is what often happens when you have a project. And what they say here in this model is that you have your intervention, which you test in really early on, and then you put it into the practice setting and it works there. And now you want to spread it to other regions. And in other regions, other ecologies, there are going to be other practices, settings, regulations, market forces, etc., different populations. And so you have a problem. So what they say you should do is constantly do your PDSAs in your spread and sustainability model as well as in your improvement model. So you're constantly changing, and the evidence changes over time. And as you spread, you have to adapt to different contexts and do some tests of applying it in different contexts. So this is a very good paper to look at. So we get to the last step, which is the step of spread. So I mentioned there on sustainability is that if you want to spread what you have to do, you have to sustain it where you are, because often what happens when you spread it, the home base starts getting weaker and the voltage fall off. So there are a number of ways you can do it. This is one of the ones from IHI, which is a breakthrough model through a series of collaborators. And that's one model that works. And I've used it on the SAFE program. We used a modified version of this in order to do this. Or as I showed you earlier, Vikram said that there's a hub and spoke model for quality improvement in rural and urban areas in India. So this is another model. There's no one right or wrong model. The idea is you must have a plan of how to do it and carry out that plan consistently. So what you have, you'll find, and this is from this is the famous one from Everett Rogers, is that we are most probably talking to innovators and early adopters. And as you spread, you're going to get into the early majority and the late majority. The laggards, the ones who come in last, are the ones who really will join at the end. But we really start with the people who are innovators. So understanding spread methodology is very important in order to get sustainability. And to do that, you need to have credible intervention. The results must be observable so they can see this improvement. It must be relevant. That must be beneficial both to patients and to the staff, not only to one. There must be relative advantage over the old way. So it must be easier to do. If it's more difficult to do, it will not last. It must be easy to install. That means if it makes it difficult, it's not going to happen. It must be compatible with the workflow. So it must be able to fit in with what we did. So when we did the situation awareness with the intervention was the safety huddle, we made it part of the process. And once it was part of the process, it was easy to do. And it must be testable. You must be able to measure it and be able to implement it. So these are the many things that we call correct. This is the acronym for innovation that you have to have. And finally, you have to build the network, and that's why we are here today. You need to build the network so that you can spread the learning and sustain it and learn from each other. So I really think that I've covered quite a lot in the last 28 minutes or so. And I really think that when you are going forward, you have to keep your eye on the basics, but remember the quality improvement reason why you're there. It's for in your case, the babies and the mothers and their families. It's for them. And it's also for your staff to ensure that they have good outcomes. it's for society as a whole, and it's for all of us. So you really have to consider how to improve. There's a whole series of network theory, and what you're doing right here is building this network across India that is going to make a bigger difference now that's formalized and now you've inaugurated. And I'm very happy to be part of this today and to be able to share my thoughts with you. As I hope I will be in India early next year, one of my last things I'm doing with ISQua, but I hope to visit in April or later, but it all depends on the pandemic. And if you really want to come to ISQua, we have a special rate for today if you want to join our fellowship program. And also we have the conference in Italy next year. It was supposed to be now, but it's going to be now next July. So I hope I can see some of you there. And thank you very much for listening to me. You can always contact me on my Twitter or on my email. Thanks very much.